What I want to do is talk about deep learning and talk a bit about next steps. But my key message is that I think with the current status of deep learning, we have an enormous potential to make applications that can be useful in healthcare. And that is my general message for this talk. I think there's an enormous potential, and what I'm going to say a little bit about is that I think we should not fall in the same trap as with pharmaceuticals, that we in the end up paying too much for applications that aren't that great. But I'll get back to that somewhere in the middle of my talk. On the other hand, when I looked at what Hessian AI was aiming for, I also want to go back to that. You really seem to be intending to take the next step and go beyond what you call the second wave of AI. And I also want to talk a little bit about that and put it into context with the applications that we have today. But I want to start by pointing out something that, yeah, probably all of you know, but still it's a surprising thing. And we do not all realize how amazingly successful deep learning is and how amazingly influential it is at the moment in science. This was actually new information for me. I recently looked this up. What Google does with Google Scholar every year, they make a ranking of all publications, all journals. And they also include conferences in that ranking. And this is the ranking from 2020 that's just out, and it's based on publications in every possible journal from the years 2015, 16, 17, 18, and 19. And what they then do for every publication, they compute an age index using only the publications from those 5 years and looking only at the citations that those publications received in these 5 years. So it's a kind of a 5-year impact factor, but then in the form of an age index. And if you do that, then you see that Nature is the publication that comes on top of the list. The last 5 years, there have been 376 publications in Nature that received at least 376 citations. And that brings them at the top. And the interesting thing is, if you then look, if you click on that number, then you see the publications that have the most citations. And it's quite surprising. Among the 8 most cited publications, there are 5 papers on deep learning. I find that quite amazing. It's not what you would expect in a journal like Nature. So we also see two papers on genetics, a paper on material science, and those are the kind of publications that I would expect to see in Nature and be highly cited. But in fact, there are 5 papers on deep learning. And as indicated with the arrow, one of these 5 publications is actually on using deep learning in healthcare for skin cancer application, the well-known paper from the group of Sebastian Thrun, who first worked on the Google car, but he now also does, he's back at Stanford and he's also doing medical image analysis. And what's also interesting is if you look at the list of publications, that you see 3 conferences in this list. So Google treats conferences and journals on the same footing. They're just publications for Google. And the 3 conferences that are on top of the list are all conferences on image analysis and deep learning. And we see the CVPR number 5, which is amazing, or even before many famous journals. And we see iClear. iClear was a conference that was set up by Jan LeCun and Joshua Benjo because they were frustrated that there was not enough room for papers on deep learning in NeurIPS. That's the conference that you see at Place 21. And actually now all these 3 conferences are in this list, and their top cited papers are all about deep learning for each of the 3 conferences. I'm just going to show it for CVPR. Then we see the list, and it's all deep learning, all papers you probably recognize from famous architectures that did very well in ImageNet, but also other famous papers like the object detection YOLO, the first paper explaining how you can easily do segmentation with ConvNets, things like that, the well-known image-to-image translation CycleGAN paper. So these papers are much cited, but people even told me that this paper, the ResNet paper from Microsoft Research in China, is the most cited paper of all papers that have been published in these 5 years. So that is an amazing achievement. It seems that deep learning is really kind of the major development in science from the last couple of years. Yeah, and you recognize all these architectures that are now well established. They are highly cited in this list. And I use the word well established because I think that's a very important achievement. I mean, there have been, of course, new architectures proposed after 2016, but they're actually quite similar to these type of architecture. If you just want to do image classification, image in and an output, a number out, then people still tend to use these kind of proven architectures. It's kind of a mature technology now. What's also interesting, if you look at the top journals, that there are 5 medical journals in the top 20. It's not surprising because healthcare is about 20% of our GDP, probably grow to about 25%. So it's reasonable that also in science, this field is extremely important. Now, what I noticed when I was opening the pages of these journals was that really within healthcare, the development from the last 5 years is immunotherapy. It was all about nivolumab, pembrolizumab, and all these other MAPs and immunotherapies that are out there. And in that respect, maybe to tell a bit about my group, we were very happy that last week we could announce that one of the faculty members in my group, Francesco Chiompi, got a big grant to actually do exactly that, combine immunotherapy with deep learning. What he will try to do is to predict which patients will respond to immunotherapy. We're using visual assessment of pathology images for that today, and we know that that doesn't work that well. It's difficult to predict in who this therapy will work. It's extremely expensive and it has severe side effects. So you really would like to only treat the patients where it will work. And we're going to try to do that with deep learning and multi-staining pathology. Now, what you can also top 20 publications matching medical imaging. And then we see that the most cited publication, the highest impact publication is IEEE Transactions on Medical Imaging. And if you're going to look in there, it's almost only, I think even only deep learning papers that top the list. That's not the case for the number 2, but for the number 3, medical image analysis, the same picture. I think with the exception of 2 images, all these papers are on deep learning. And also here in this list, there is a conference, highly rated. That's the MICI conference. And well, as most of you will know, the most cited paper there is the UNET. And in fact, I've been told that this is the most cited paper in medical image analysis ever. And the number 2 is the 3D version of the UNET that the group of Olaf Ronneberger published 1 year later. So in science, in literature, deep learning is really extremely popular. And what we are now also seeing is that it's such a mature technology that you can develop products on top of that. I want to show that here with this overview that we made on our website Grand Challenge. This is a website that we started in 2012 to make it easier for people to organize challenges. So that's in the name. But what we've done the last couple of years, we are using this platform, this web-based platform now for every project in our group. And we also put in tools to collect data, to annotate data. Also to have reader studies so that you can compare the performance of algorithms with human experts. There's also the possibility to put an algorithm that participates in a challenge or is just a separate algorithm in the platform in the form of a Docker container so that other people can upload data to the platform and get the output of the algorithm on the image. and can also view that in the web browsers. But if you look at the overview of products we made, that's a PhD project in my group. We tried to set up an overview of all the AI products for radiology that are available with a CE mark so that they can be used clinically in the European market. And this is already a slide that's a little bit older, so the numbers are actually a bit higher if you would look that up today. But you see here that there are well over 100 products available with a CE mark using AI for radiology. And I think almost invariably they use deep learning and supervised classification to build these tools. And it's coming from close to 60 companies. And the interesting thing is, if you look at the list of these companies, you see that here for the first few that they are all recently founded, and also the vast majority of products have come on the market very recently. So they're not widely used yet because they're simply too recent. And that is what's going to be interesting to see in the next 5 years, if people are actually going to use these products in practice. So I think deep learning is there amazingly successful. Now let's take a step back and look at what you are trying to achieve here with this Hessian Center for Artificial Intelligence. There is a mission, which I found actually quite a difficult sentence to read. But next to the mission, there is also a vision. And this is the vision that is listed on the website. It says what you are after is the third wave of AI. So it says most of AI in use today falls under the categories of the first two waves of AI research. And the first wave was rule-based, written by people aiming to cover every eventuality. Well, the way it's written here, you can already infer that it didn't really work that well. And we are now in the second wave of AI, where we are using statistical learning to arrive at an answer for a certain type of problem. Think of image recognition systems. And then you say we envision a future in which machines are more than just tools that execute human programmed rules or generalize from human curated data sets. And that implies a bit of criticism, right? It says what we're doing now, it's just tools that generalize from human curated data. And I think that's a little bit too negative. I understand that you want to give your real vision of what should happen next, but I want to argue in this talk that these tools can be extremely important and successful. And you say that rather the machines we envision will function more as colleagues than as tools. So apparently tools are not yet colleagues. But in fact, I think tools are even more than colleagues. They can take over the work of doctors. And I think that is an essential aspect to keeping healthcare affordable. In many of my talks, I want to stress that we already have extremely good healthcare, but it's extremely expensive. And if we can automate parts of it, we can keep it affordable, and we can also make it accessible to parts of the world where this healthcare is now not yet available because the human expertise is lacking there. But what should this third wave of AI look like? Well, it should acquire human-like communication and reasoning capabilities with the ability to recognize new situations and adapt to them. And I agree that that's kind of a holy grail. So I want to say something about that at the end of my talk. But yeah, when you say, for example, a third wave AI might note that a speed limit of 120 kilometers does not make sense when you enter a small village. Well, if I just ask Google today, what is a sensible speed limit in a village? Google already knows this. So it should be fairly easy to take deep learning tools and add these kind of rule-based systems that already exist to it so that it gets at least some kind of common sense. But you can discuss about whether AI systems today are still very stupid, as some people said, or the introduction talk here said that they had very little influence in the COVID period. I want to return to that as well later in my talk. Okay, so what I think is important to realize is that a lot has happened in the last couple of years. So I've been giving a lot of talks at radiology conferences, and I must say that like 2 years ago, there was still quite a lot of confusion. Radiologists really doubted if all these AI tools were actually working and would be good enough. There were not many products available yet, and it certainly didn't help that Jeff Hinton made a statement at a conference, but he later repeated that in interviews, that we should stop training radiologists because there was no question that deep learning would do a lot better. So it was no use training these expensive people. So that created kind of a negative discussion, like this is not true, and it's AI actually is very bad, etc. But I think now in 2020 the situation is a bit different. There are now so many publications out and so many products available that I think most radiologists actually believe that AI has potential, but they are very critical on the validation. And I think that's a good thing. We now have these more than 100 marketed products available. And in general, the perception is, yeah, Hinton was just completely wrong. And even Hinton himself has kind of admitted that in another paper that he wrote together with a head of a radiology department from Toronto. And you see that radiologists have regained confidence. They will not lose their job, but actually they will just get nice AI tools to make their jobs less boring. And I think that is now the general feeling. And I argue a little bit with that because I think these tools are more than just little helpers for radiologists. Such tools will definitely become available and are among these products, but they are also used in different ways. And that's what I want to illustrate with a couple of examples now. So I think the landscape for AI products should in fact be classified a little bit differently. I think there are three types of AI products. There are products that really aim to replace a task of a radiologist. So not replace the radiologist, because that's impossible. The radiologist does way too many things, and we can only make narrow AI solutions today with deep learning. But you could replace a task in the repertoire of a radiologist. You can also develop a tool that helps the radiologist perform a certain task, and it can either make the radiologist more accurate. There's a lot more emphasis on that. But in fact, more important is probably to make the radiologist faster, because there's a huge shortage of radiologists, and the workload for radiologists, and I think clinicians in general, has only grown over the last couple of years. And we also see this now in the COVID crisis with overloaded hospitals, that we really have a shortage of personnel. And then there are also some tasks I want to show, at least one example where a software does something that a radiologist does not do today, and I think probably will never be able to do. So that's a completely different realm of applications. But it's more than that. So for a radiologist, it's important to realize that once there is a tool on the market, it could also be used directly by the treating clinician rather than the radiologist. So that's something they have to be aware of, but it could actually help them to reduce their workload. And the other thing is that once an assistant tool is available and it gets better over time, at some point there's really no need to still involve the radiologist. So an AI assistant can become over time an AI replacement. And that is also what I show some examples of. So let's start with what we found is by far the most widely used AI product in the Netherlands. We did a questionnaire and we looked at what kind of products are actually in use. And the BoneXpert, developed by Hans-Henrik Todberg from Denmark, is used in many, many Dutch hospitals. And it's super handy because it prevents or it removes the need to painstakingly score all these bones in the hand to arrive at skeletal age of a child. And Hans-Henrik Todberg did a questionnaire a couple of years ago among his users, how they actually use his product. And he found that only 10% uses it as it should be used in the classical sense of being a helper. Only 10% performs a full manual rating first and then uses the computer as a second reading. In fact, 40% relies on the rating of the software, but then looks at the image if there are any other findings. Well, these findings are very rare because these are healthy children that are either too small or too large, but typically do not have other findings. And in fact, half of them no longer look at the images. And in fact, the referring physician, the pediatrician, looks up the BoneXpert bone age and immediately gets the result. And that is a replacement task. So BoneXpert is mostly used as a replacement task, not as a tool to help the radiologist. And this is interesting because I think we are seeing this in more products now. And just to illustrate to you, Arjen already mentioned that we met in the 1990s and I was working on a chest X-ray. I'll talk about that in a moment. It takes a very long time to develop such products. So when this is work, what you see on the left, what a master student in my group, Meinert Niemeyer, did in 2003. Then we were already working on automatically detecting this bone age. And when I found out that Hans-Henrik Todberg was working on this, I gave him all our data and we helped him to get started because he was eager to really develop a product. And I had only a master student, Meinert Niemeyer, who then became a PhD student, but working on a different topic, namely retinal image analysis. And later he went to Iowa and he's now the chief of scientific technology at IDX. And they have made a software that analyzes fundus photographs for diabetic retinopathy. And it is the first product that was approved by the FDA as an autonomous AI system, meaning that people can use that software. No doctor has to look at the fundus photograph, but if the software considers the image suspicious, then a patient is referred to an ophthalmologist for further workup. So we are seeing now that finally these autonomous systems are coming on the market. And for me, that's amazing. I mean, I've been working on this in this field for such a long time, and it's really unbelievable for me. For a younger generation, it's like, oh yeah, with deep learning and it works. But it's unbelievable for me that this actually works now at the level of a radiologist, or in this case, an ophthalmologist. And to show you that this is just one little task, this bone age is the skeletal age on a healthy hand radiograph. But of course, there are many other reasons why you would analyze hand radiographs. And we have recently developed an algorithm to detect fractures of the scaphoid. That's one of the bones in the hand, and that's typically the bone that you break because you use it to break your fall. So people who arrive at the emergency, you really have to carefully look if there isn't a scaphoid fracture. And we have done an observer study where we compared our AI software with 11 musculoskeletal radiologists, and the software actually outperformed all the radiologists by a very small margin, but it was a little bit better. And this software is also now available as an algorithm on our Grand Challenge platform. Well, then the example where I did my PhD on, as Arjen already mentioned, analyzing chest radiographs for detecting tuberculosis. And also here, it took a very long time before this became a product, but in 2014, it was eventually certified. And it's now used in actually already 45 countries, screening over 7,500 people per day. And we have also made a version that can also look at COVID-19, and that's currently being deployed in 4 countries in Africa. And we have shown that our last version actually performs comparable to a radiologist, and the latest version, version 7, which is not released yet, we know that the curve has been improved, especially in the beginning of the curve here even further. So it's now outperforming all readers. And this is used in many countries in screening campaigns where they put portable X-ray machines in a bus. People line up to get an X-ray, and if the software believes the X-ray is abnormal, then they cough up sputum for an expert test, a PCR test like you do with COVID. And it runs on this little box computer standing next to the X-ray machine. As another example of software that started as an assistant or is an assistant now. It's for lung cancer screening. It's something we have developed with Mavis Medical Solutions. It detects nodules, it segments the nodules, and it classifies the nodules, and then produces a ranking of the report according to the Lung Rats guideline. So at the moment, it's a workstation that helps radiologists to read quicker. But in fact, in our research version of the software, you can click on report immediately if you wanted to. This is disabled in the certified version because it's not officially allowed, but you could get the immediate analysis of the software. And we have shown that it is comparable to radiologists. So you could make screening and lung cancer screening with CT will be extremely time consuming for radiologists. You could make it a lot more effective if you would use these AI algorithms. It's not out there yet, but I believe it will come. And it is actually coming in mammography. We have another spin-off from our group ScreenPoint. And last year we wrote a paper where we compared the standalone performance of that software with data sets that had in total been read by 101 radiologists. These are typically data sets used for FDA studies. And we found that the AI system standalone performed better than 62 of the 101 radiologists. So that is really an interesting finding. And what you have to realize is that there are now a lot of these software systems on the market, and they are only getting better. So over time, this number will go up. That's what I predict. And recently, there was a study in JAMA Oncology from a group in Sweden who used data from the mammography screening in the Stockholm region. And they compared 3 different AI systems, commercially available systems, and found that the best system was actually outperforming both of the readers in the screening program. And then they wrote another paper in which they did, what I found a very bold proposal how you could use this. And this is a proposal coming from radiologists, not from AI researchers. But they actually proposed to let AI read all the mammograms and then immediately take the 60% of mammograms with the lowest score and don't let these mammograms be read by radiologists. Just immediately say that these women are healthy and they can come back in the next screening round. The remaining 40 is what, the remaining 40% is then double read as usual. And then 3% of those 40 or 3% in total will be read as abnormal and they will get diagnostic workup. But they also propose that this remaining 37% read as normal in the double reading process would actually be also analyzed by AI. Well, it has already been analyzed because everything's analyzed by AI. And the 2 to 5% with the highest scores, they propose that they get supplemental imaging, for example, MRI. And they actually show in their simulation that if you do this, then you do not only save a lot of radiologist workload by more than half because of this 60%, but you also preemptively detect a substantial proportion of cancers that would otherwise be diagnosed later, because among these 2 to 5% cases, there are quite a few cancers. And then they say that in the end, you would have to do a retrospective trial in other settings because it's a single center study, but also a prospective trial. And that is where I'm a bit worried about, because I know from experience, if you would want to test this particular algorithm prospectively, it would take you many years. You would first need to get funding, then you would have to run that for a number of years in order to collect enough cancer cases to have enough power in this trial. And then you would maybe find that this particular algorithm with the 60% and the 40% and the 2 to 5% would work. But by that time, the AI software, which is made by a lot of companies these days, would already be much better. So I think that these long prospective trials have the big drawback of really slowing down innovation. And the great thing about software in this case is that you can actually use retrospective studies to validate it, because you're not treating the patient with the software. It's not like if you would have an AI robot that would do surgery on patients. Yeah, you can only do that once, but you can analyze data with many different software packages retrospectively. So I think we have to be aware of that and not say too often that we need to do this kind of prospective trials that you would do for drugs. Companies would like it because then they would kind of get a monopoly, because this would be the only AI software prospectively validated to do that. And maybe there's already much better software on the market which would not be allowed to be used because there hasn't been a prospective trial. That's something that I worry about a little bit. Now, let's look at software that does things that are very difficult for humans. For example, the software from the company Icometrics. It does a very extensive analysis of brain MRI of patients with MS, and I think it will be very difficult for radiologists to do this kind of analysis. And another example is what we are doing in the company that I co-founded, Tirona. If people have very severe COPD, it can help to put valves in the airways going to the most diseased part of the lung. And these are one-way valves where the air can only go out. So the result is that these people, the most sick part of the lung collapses and the reasonably healthy part of the lung gets room to breathe again. And this can really make a difference in patients with severe COPD. It's not a curative, it doesn't really cure you of COPD, but it makes your lung function a bit better so you can live a reasonable life again. The problem is that it doesn't always work, because if the fissures are incomplete, then the valves that take the air out of the sickest part of the lung, this part doesn't collapse because the air goes back through the holes in the fissures. So you have to look at a CT scan and look where the fissure is incomplete to predict if this treatment is going to work. And that's the kind of analysis that Thirona does with AI software and humans. And over time, we are adding things to this software to make a personalized prediction whether this treatment will work. And I think it will be very difficult for a radiologist to make such an accurate prediction. And right now, over 400 hospitals in the whole world are sending their CT scans to Thirona for this specific analysis. And I think this is a type of AI applications that we're going to see more often. The interesting thing is, if you look at the marketing material around this service, the radiologist is not included. It's just showing the analysis of the CT scan and the pulmonologist who decide whether or not to treat the patient. So that's an example of what I meant, that these kind of tools, they're not always tools for a radiologist, but they are sometimes rather tools for referring physicians. And then one example of COVID, when we were sent home during the first peak, our hospital started to make a lot of CT scans. At that time, because there was a huge shortage of PCR tests, and when sick patients arrived at the hospital, you have to make a decision whether you're going to take them in or not. You cannot let them wait for half a day. So people started to use CT for that. And now still we have the problem that sometimes the PCR test is negative. That happens in actually about 20% of the very sick patients that arrive at the hospital, but they're really suspicious for COVID, suspect for COVID. So CT analysis is then used to arrive at a working diagnosis, and then typically a later PCR test is positive. So we implemented an AI system to automate the CORADS guideline. The CORADS guideline was proposed by Dutch radiologists and is now the standard for reading CT scans for COVID suspects in the Netherlands, and it's also used in many other countries. We published that in radiology, and in fact, it's the most downloaded radiology paper today. But we looked if we could do this with a computer. And we developed an algorithm to automatically segment the lobes and then segment the lesions in the lobes to compute the CT severity score and to do the overall classification for the CORAD score, taking the whole scan into account and classify it from 1 to 5. So we published that and also shared the algorithm on Grand Challenge, the lobe segmentation. It's a variant of the UNet, will not surprise you, with a couple of new elements, but in practice, the UNet just works very well for segmentation. And what I found interesting was when we wanted to segment the lesions in the next step, we in fact had several teams trying out things. And we found that just using the No New UNet, which has been developed in Heidelberg, and you can download it, and it will train a UNet for a 3D segmentation task, and it will play around with all the settings and performs an automated hyperparameter optimization. And it worked out of the box, and it gave the best results among all the things that we tried. And for me, that again proves that deep learning is now a stable technology that's relatively easy to apply to lots of different problems. And then for classifying the whole scan as COVID positive or negative, we used another previously published architecture, Inception 3D. And together with a couple of tricks, the slide doesn't really explain all the tricks, we got quite good performance comparable to the cutoff points of the radiologists. You see them with all these circles here for predicting COVID. And here you see that, well, actually radiologists are still a little bit better. We only trained the system with a couple of hundred scans, so probably we need a little bit more data to give the computer enough exposures to the patterns that you see in this patient group, and improve a little bit further. And in fact, this Inception 3D architecture, we also just took it from another paper where it was shown to work well for nodule classification. And to me, that illustrates that deep learning is a mature technology where you can take proven architectures and just adapt them to your current task. So I think this is kind of a figure from a recent editorial that explains the process that we are seeing now. I don't think it's that there will be some kind of breakthrough that we suddenly get much better technology and we suddenly can do autonomous AI. Rather, I think that products will evolve gradually from assisted to autonomous, and they can be placed somewhere on the spectrum from improving accuracy to improving speed. And some of them address a clearly established task that is exactly done also by human experts, and others are working on applications or extracting biomarkers that are very difficult for humans to extract. So basically, on various axes, these products are situated somewhere, and they actually change over time when they get better, are trained with more data, etc. Now, and where are things going in the future? So what is the agenda for Hessian AI? I think I'm extremely impressed by what I recently read about what GPT-3 is doing. And I think it's interesting to note that we started in 1998 with LeNet, the first working convolutional neural network, which had 60,000 weights. It took about 15 years to get to AlexNet with 60 million weights and really make a breakthrough in object classification in images. And now recently, in June this year, OpenAI released the third version of their transformer architecture for text analysis, and it has an amazing 175 billion weight. So it's another step of 1,000. If you would make another step of 1,000, you get close to the number of synapses that we presumably have in our brain. And the interesting thing from the paper is that they really show in a number of experiments that adding more text and more weights, making this network bigger, immediately leads to improved performance for the, I think, over 50 tasks that they apply this network to in the paper. And that is a discussion. When we are going to do reasoning, do we have to get some breakthroughs and not use deep learning or use it in a completely different way? Or will this just all be done eventually by deep learning because we invent a couple of new architectures, etc., that make these networks work even better and allow us to train these very big networks? Well, Geoffrey Hinton, this is an interesting blog post from a couple of days ago, believes that everything is going to be deep learning. And he mentioned the transformers for text analysis as one of the recent breakthroughs that allow us to make basically networks that derive really good vector representations. And that's for him what it is all about. And in the interview, they also ask him, well, shouldn't we look at other approaches in AI that are derived from cognitive science? And Hinton gives an interesting answer that already a long time ago, there was a debate between two schools of thoughts. One school thought that you were actually manipulating pixels, arrays of pixels as visual images in your mind. And the other school of thought was that that was nonsense. You have to work with hierarchical structural descriptions. You have to work with symbols. So that's the classical AI. And he says they are both wrong, and people just made the same mistake. They think that we should manipulate pixels because that is our way of storing images, and it's a representation we understand. And similarly, the symbol people thought we manipulated symbols because that is how we represent things. We use symbols. But I think they're both wrong. What's inside the brain are these big vectors of neural activity. Well, we'll have to see what comes out of it. But I must say, I really advise you to read the GPT-3 paper, where they talk about this huge network that they made, and where they say that the normal way of working is, if you want to let such a big network do a particular task, is to fine-tune it. But they are not using fine-tuning in all the experiments that they show. They show that this network is so big that it can do something they call in-context learning. You just give it some text that describes a task, and then a prompt, and it gives the correct answer. This is the most difficult setting, zero-shot learning. In the one-shot learning, you also give it one example of input and output, and then you start to ask it questions. And in few-shot learning, you give it a bunch of examples. And they show that if you do it in this way, you can actually fine-tune. You don't fine-tune it, you just give it a new task by in-context learning. It only does this via a forward pass. There's no gradient updates. I find this really intriguing that this apparently works with these big networks. And they show here, this is the average over all tasks that they have considered, that in fact it doesn't work very well with small networks. And this is the biggest network. This is the size of the Microsoft network from January 2020, the Turing transformer. And if they make the network bigger, and they've also trained it with much more data, the performance goes up enormously. So that is the message of my talk. I think deep learning is amazingly successful, well established, and ready to be widely used in healthcare. It's very interesting to consider all these potential new developments, but I think we should be really happy that we can actually make tools. If you want to call them just tools, that's fine. But these tools that we can make now with relatively standard technology, they can have a lot of important applications in healthcare. And I know that from the rest of the talks you get today, people will talk about next steps and what still needs to be done and what doesn't work. But I would like to start the day by emphasizing that we should be extremely happy that we have this technology now that already works so well. Thank you.